Hi, everybody. Welcome to today's webinar. I'm just going to give it a minute or two while we allow everyone in and we fill the room up. We'll be getting going in a minute or two. Hi, everyone. Great to see so many of you joining us promptly at 2 o'clock. We're just waiting for a few more people to join. When the numbers are stable, we'll get going. In the meantime, you can introduce yourselves to us, to each other in the chat panel. It's always great to hear what union you're from and where your workplace is. Okay, everyone, I will get going with some of the housekeeping while the room is filling. So, as I said, welcome to today's webinar. We are going to be talking about air quality at work and preventing airborne viruses at work. I'm joined by two amazing speakers today who will talk a little bit more about in a second. So, our usual housekeeping, we do have captions for the webinar. If you click the button at the bottom of the screen that says more, it's got 3 dots. There's an option there to have captions on the screen if you would like to follow along with those. We are, of course, recording today's webinar, as we always do. So if you miss anything or if you need to leave early, please don't worry. We will send everyone who has registered a link to the recording. We'll also share any resources that our speakers suggest or share with us. Great to see many of you already introducing yourselves in the chat. As I said, we love to hear about what's going on in your workplaces. So do use the chat to tell us about that or to exchange any advice or tips with each other. And we are going to be taking questions for our speakers. So at the Q&A panel, which is again at the bottom of the screen, please post any questions there and we will try and answer those after we've heard from our speakers. So, as I said, we have two great speakers today. We've got Dr. Jonathan Fluxman, who is from Doctors in Unite, and I'll be getting him to say a little bit more about his experience in a minute. And we've also got Professor Raymond Agius, who is an expert in these areas and has a long career in lecturing about this and as a doctor. So I'll be getting him to tell you a bit more about that. So, air quality and viruses at work. We all know that this is an issue, especially post-COVID. So we're going to be looking at some of the evidence that we've got that this is still a problem, and crucially, what some of the things are that we can be doing in workplaces to help mitigate this and how to protect members. We're going to hear from Dr. Jonathan Fluxman first. So can you be getting your presentation up, please, Jonathan, while we just sort all that out, and then we'll be ready to go with you in a second. And one final thing from me, everyone who attends this today live will receive a TUC digital credential from us to show that you've attended. We'll be emailing that out to you either later today or first thing tomorrow. So do keep a lookout for that, please. So, Dr. John, it's over to you. I'll let you kick off with airborne infection risk in the workplace.
Thank you so much, Anna. And, grateful thanks to the TUC for putting on this webinar. The TUC Education Department has been really supportive over the years, and it's great to be working with you on this. And also, a shout out to Raymond. It's a pleasure and a privilege to share a platform with you again, Raymond. You've been a great advocate and colleague in working in this field, and I think our voices together, hopefully we are helping to move the dial. And the recent revelations of the COVID inquiry this week have been very interesting, and we can maybe talk about that in the chat. Okay, so this is what we're going to be talking about. There's my email address. I'm COVID lead for Doctors in Unite, been doing this work really since day one of the pandemic. I'm a retired GP, retired just before the pandemic started, and then went back and worked for a year for the COVID service, and then the government shut that down. And since then, I've been a campaigner and an advocate, so to speak. My email address is there. If anybody wants to get in touch, please don't hesitate to do so. Okay, so I just wanted to underline the message that COVID is not over. I know you used the term post-COVID. I would have a little bit of a pushback on that. I know the narrative from government and all the institutions is it's all over, nothing to worry about, and let's move on. But as this graph shows you, COVID cases keep coming, keep coming, keep coming, and there is no reason in the world to expect them not to keep coming if we persist in not doing anything about it, i.e. not addressing transmission. Now, this data is slightly different. These are hospital admissions per 100,000 population over the last year. But the usual, peaks and troughs of the graphs we've been looking at for the last 4.5 years about cases, deaths, hospital admissions, and so on and so forth. And I just wanted to draw your attention to the fact that this is an all-year virus. It's not a seasonal virus like flu. And you probably have heard that on the TV and on the radio. They trot out these so-called experts to say, oh, it's just like flu now. It's a seasonal virus, nothing to worry about. This was the big summer wave we've just had. Okay, and I don't know about you, but loads of my friends and colleagues and people I just know came down with COVID. Okay, so some basics again. Many of you will probably have seen this image before. I've tweaked it a little bit. It's taken from the wonderful expert Prof. Lindsay Ma, who's a US aerosol scientist who was one of the key voices early on in the pandemic to say to the WHO and to all of us, oi, this thing is airborne. Stop talking about droplets and hand washing. That's not going to stop transmission. And this is her diagram. So there's two ways you can get infected through the air. That's if you close up, that's so-called near field or nearby airborne spread. These big blue drops are the droplets. Now it's possible to get infected by that, but the overwhelming majority is inhaling the virus into your lungs, and that's how you get infected. It's not touching something and rubbing your eye. And then this part of spread is very, very important, so-called super spreading. In other words, one infected person in the room spreading the virus throughout the space, and all of these people potentially can get infected because the ventilation is inadequate and there's virus in the air. Now, that super spreading part of airborne spread is actually the dominant way that this virus spreads. And I wanted there's a few slides to underline this point, because we all have we've been told of an incorrect model of spread between people. And here's some studies, I won't go through the detail, but basically saying this, that super spreading predominates. And a small number of individuals, this study showed 5%, accounted for, sorry, what's the number in this one? Or 80% of cases. And very interestingly, 70% of people who got an infection didn't pass it on to anybody else. So it's that very skewed distribution where you get a small number who infect loads of people. And the second study shows the same message. And this is another paper which says the same thing again. And then just the last quote in red at the bottom there. Our mental picture should not be that most people transmit to 2 or 3 other people, but instead a small number of infections dominate the transmission, while most others fail to have any secondary infections. So it's not the one-to-one spread like here, okay? It's that model. One person infecting 10, 12, 15, and then each of those potentially going on to infect other people. And so it's clusters. And I'm always reminded of this cluster bomb, this terrible weapon, which is one bomb, one big bomb, and explodes, and it releases all these other little bombs, which are like these, which can also explode and injure and kill other people. And here are some real life studies to show that phenomenon. This is the famous call center in Seoul, in South Korea, in early 2020. And it showed that these are the chairs in the call center, and all the blue colored chairs are the people who got infected over a very small number of days. And when you see that high peak of cases over 2, 3, 4 days, you know that's a super spreading event. It is impossible, and I'm sure you'll agree with me, that hundreds of people, well, in this case not hundreds, but dozens and dozens of people, all got sick in the community at the same time and came into one workplace, so that they all the cases were collected in the workplace. Obviously, what's happening is you've got 1 or 2 index cases who spread it in the same shared space again, and infecting lots of people, and then they go out into the community and infect their households and their local communities and things. And this is the famous outbreak in Greencore, the Greencore factory in Northampton. They make sandwiches for M&S and other companies. And in a 2-day period, 3 days maybe, they had 300 cases. And this is a picture of the factory floor. We don't have any information about the ventilation, but to explain that, in no way can that ventilation have been adequate for all these workers on the factory floor. It's noisy, it's probably kept cold, which enhances spread, and lots of people talking, and probably talking quite loudly, so there's lots of virus expelled into the air. And unfortunately here, the surprise, the employer blamed the workers for not socially distancing, and disgracefully, the local director of public health agreed with them. This is an interesting study from China. They gave all the kids these little devices to wear, which tracked how close they were to one another. And then they tested them for infections and so on and so forth. It's quite a complex study, but the bottom line is that long-range airborne transmission was dominant. It's not when the kids were close up. Of course, some of them did get infected that way, but most of the infections were actually in the shared classroom or in the canteen, where they were all in the sharing the same air and getting infected, probably again from 1 or 2 or 3 infected children. This is a study again from South Korea, a very beautiful diagram, which shows this super spreading phenomenon again, where you have one index case and you see all of the cases that arise from that. And this is the Taekwondo school and various other congregate settings in that school setting. This is a big US study that showed that it is children coming home with COVID that spreads COVID in the household, coming home from school, should say, rather than kids getting COVID at home and then taking it into school. The same message. Because time and time again, we are told, oh, it's never in the workplace, not at school, it's not in the hospitals, it's in the community. You're always getting COVID in the community, like there's a fountain in the high street spewing out COVID virus, and that's the sole source of getting infected. And obviously it's not. And this is another study in France which showed the same thing, that school-age children are the predominant spreaders of COVID in the community. And this is a very pretty diagram showing you how much COVID can spread in the right environment through the air. Now, this is MERS, which is a different coronavirus, and this is 2015 in South Korea. And this is in various hospitals. And you can see, for example, this one index patient, well, the outbreak actually started with this person here. I think he infected about 30 other people. And then this guy went to an A&E department and spent about 36 hours in the A&E department, and he infected all of these people. And the epidemiology was very carefully done. So it wasn't as though they were just making assumptions. They were able to track it down to a single infector. And a number of patients and a number of healthcare workers died from that outbreak. And that's MERS, right? Now, MERS is less contagious than COVID-19. So you can see why we had such exponential spread at the beginning of the pandemic, and why we're repeatedly getting these waves through the community. This is a highly, highly contagious virus. The other important point is that we knew about airborne transmission way back. This is the work of Lydia Morawska, another world expert on aerosol transmission, who's done some fantastic work, and he's doing a lot of work in Australia to get air quality standards into workplaces, which is a really important step. And in fact, I was just doing some reading the other day. No, in fact, it was a webinar yesterday that I watched. One guy said he showed two books that were written in 1955, was one, and the other one 1961, by Wells and Riley, showing that viruses can transmit through the air. So we've known this for a very long time. And there's a paper down here, if anybody wants to get into the real detail, by Jimenez, who's another world expert, on why the establishment has been so resistant to accepting airborne transmission. So coming more to our sort of home territory as trade unionists and workplaces, I just wanted to show you this slide. People may remember in September 2020, Matt Hancock was interviewed on TV, and he said, all workplaces are COVID secure. It's quite safe for you to go back to work. And this was the time when, after lockdowns and things like that, and the government was desperate to get people back to work. And instead of being open and honest and saying, we haven't controlled things, but we are going to work on this and improve it, we were given false reassurance. So at that point, I said to myself, this is absolute rubbish. And I just went on to Google. And in about half an hour, I found 15 outbreaks in workplaces across the UK, household names, in a lot of them in the food industry, Greencore, B&Q, Iceland, Asda, you name it, they're all there. And the common thing that they have is they've got big congregate spaces where workers are all sharing the same air together. There's 15 outbreaks, over 1,600 cases. And then what did Hancock do? At the inquiry, right, he admitted, this is the COVID public inquiry, on the 1st of December last year, under cross-examination at the inquiry, he admitted it became clear that in early summer 2020, in fact, aerosol airborne transmission was more important than droplets. So the government knew that he was the health minister, right? But so what does early summer mean? June, July, maybe? Sorry. 2 months later, 3 months later, he's standing up on national television and lying to us all because there were no airborne protections in the workplace. The government had not mandated them, and very few employers were doing it. So this is an example of how the government and the authorities generally have hidden this pandemic, have lied to us, and given us false reassurance. And the results have been absolutely disastrous. And that's why we've had more than 250,000 deaths. And of that, we've had tens of thousands of workers died, and hundreds of thousands have got long COVID. Okay, so just coming towards the end, just to remind you, when you're in your workplaces and vulnerable spaces, this is how hot transmission happens, okay? It's the number of people in the space. It's how much COVID is in the community at that given time, what people are doing. Are they talking quietly? Are there lots of talking and shouting and laughing? How big the space is? Time in the space is very important. And this is one of the reasons why workplaces in particular are such drivers of the pandemic. If you think about it, we all spend 8 hours plus, 10, 12 hours sometimes for healthcare workers doing shifts in a space which has got lots of COVID. It's not like 20 minutes in the corner shop, okay? You're much more likely to get infected where you spend a long period of time with other people who might be infected. And there's various other factors. So this notion, this mantra that every employer and manager says, you got it in the community, it's not correct. More likely than not, this is where you get it, and this is what drives the pandemic. Just a few quick slides to show you that the interventions to minimize and reduce airborne transmission work. The other thing the denialists and the minimizers say is that, oh, okay, maybe it is airborne, but the protections don't work. They do work, and those statements are usually made by infection control doctors and nurses who are completely ignorant of the science. This is not medical science, this is physics. The engineers are going to solve this problem. And I say this to you as a doctor. We don't know how to deal with this. We must leave it to the experts who do know, and those are engineers, aerosol scientists, and so on. And this is a graph showing very well that the more ventilation there is, the much less transmission. The study showed an 80% reduction in SARS transmission in well-ventilated spaces in schools. This is an air filter. Again, some more data showing that they work. And in some hospitals, particularly in Edinburgh and Cambridge, they've been doing this and studying it. I was happy to see that in East Suffolk, they bought 400 air filters for their hospitals. And again, going back to Jose Luis Jimenez, the expert in the US, he studied this incredibly in depth. And he says that 2/3 of transmission can be reduced by cleaning the air. And this is just a slide on masks, which shows that surgical masks are not as good as FFP3s, i.e. respirator masks. These healthcare workers worked in ICU. They had a 15% infection rate. All of these healthcare workers had surgical masks. They had more than double. Who had the most COVID of all? Not the clinicians, although the numbers are not that different, but the highest group were actually the housekeeping staff, the porters, cleaners, and so on, who keep the hospital running. And they had the highest COVID rates of all. And just to add, Black and Asian workers had double the rate of their white colleagues. Now, I don't need to teach you how to suck eggs. You know all about this, what the rights and responsibilities of safety reps, but you can use these rights to investigate your workplace. You can carry out inspections. You can do a ventilation assessment. You can do a CO2 mapping of your workplace. And you can get information from management. How many workers are off sick with COVID? How many people have had to leave because of long COVID? And so on and so forth. And the usual risk assessments can be done, of course. And that's just more of the same. And I just wanted to end by a word on our COVID conference, which is in 10 days' time. And it's to bring together trade unionists, campaigners, and advocates to get organized to demand protections. Because we know as trade unionists, you ask for something and your employer doesn't just say, oh, okay, I'll do that and give it to you. Often you have to get organized, you have to declare a dispute, and sometimes even take industrial action to get the proper health and safety protections in place. And this is on the healthcare workplace, the workshop in particular. People are interested, but there's a whole program. The links are here, and I'm sure Anna will share this with you afterwards. So I'll stop there. Thanks very much.
Thank you so much for that, John. I think what is really helpful for us to highlight is what reps can do in workplace. I think it was maybe 2 slides ago. I think some really important things there that you can do as part of your role as a safety rep. You know, you're entitled to work with management on risk assessments, inspections of the workplace, monitoring sickness absence, all those things that you've got the right to do as part of your role. Maybe it's a good idea to start including an element on infections, within that. We'll be coming back to Dr. John shortly. So now it's time to hear from Professor Raymond Agius. While he's loading up his slides, I'll just remind you to post any questions you've got for our speakers in the Q&A panel, which is at the bottom of the screen. And we will be sharing the presentations and any other resources with you all later today or first thing tomorrow, along with the recording. So more from me in a bit. Over to you, Raymond.
Thank you very much, Anna. Thanks, John, for that excellent presentation. And thank you all of you for coming here today. Yes, I recently contracted COVID for the very first time. in this last wave. So I know what it feels like. This is a disclosure of my interests, just so that everything is transparent. Some of you may have been following the inquiry. It reminded me of this quote by Aldous Huxley, because actually lots of stuff which people are saying we learned from COVID, as John showed earlier, we'd actually known all those things way before COVID. So if you try and see what people are doing in workplaces at the moment, I'm really quite depressed by people who are talking about business as usual, living with viruses, a new normal, without actually saying what that new normal is. Some people say, well, let's wait and see what the inquiry says. Well, module 3, which is about the effect on the healthcare, and including healthcare workers, which I think would be a very important one from a health safety standpoint, won't finish taking evidence till the end of November, and it's likely to be another maybe 9 months before we get a report. So why should we be doing something? There still is, as John said earlier, a significant risk of contracting airborne infections in the workplace. It's not just coronaviruses, influenza, respiratory syncytial virus, and others. And for some people, this means just more than just in health. This actually means death, especially for susceptible ones, and especially for those who are vulnerable through a high workplace exposure. So this costs for people, costs for workplaces, and costs for society. What's also very important to realize is that unless we do something about controlling the risk of infection workplaces, we'll be back to square one when it comes to a future pandemic threat. We will be just as weak as a society then as we are now. Indeed, if we leave this pool of coronaviruses or influenza just out there replicating in the community, they're likely to throw up new variants, which will spread better, which will be resistant maybe to a significant degree to the vaccines we've got. And hey presto, we will have another pandemic, and we will be just as poorly prepared as we were for this one. It's very difficult to get good data. If you look at sickness absence data in the UK, it's very badly classified. So 29% of occurrences of sickness absences are for so-called minor illnesses, which we are told includes coughs, colds, and flu. 24% are described as other, which we are told includes coronaviruses and infectious diseases. 8% are respiratory conditions, which in fact overtook mental health conditions to become the fourth most common in 2022. And lots of people in caring, leisure, and other service occupations had contributed to those sectors having the highest sickness absence rates in 2022. RIDO data, which I don't have time to go into, but I've criticized in the medical and legal literature being very inadequate, they show a gross underestimate, but of a huge problem, as John said. Sorry. Now, what should we do about it? Well, I don't think we should look at the infection prevention and control guidance. It is, as we knew at the time, many of us, John and I, and as is being apparent in the proceedings of the inquiry, sorely deficient. There is one section of that guidance, though, which I literally have framed and hang on to. And it actually says, it's a disclaimer, saying this is not going to provide you with protection in terms of the Health and Safety at Work Act following this guidance. You've got to do other things. And that, I think, has got to be something that we have got to use when people quote this guidance back at us. It is explicitly saying this does not cover your obligations at law. So we need to do something to, at the very least, fulfill or make sure that employers fulfill the obligations at law. In my judgment, what needs to happen needs to be a comprehensive guidance, or better still, an approved code of practice After all, HSC has produced these for Legionella, for asbestos, for silica. The list is endless. And even though we haven't had, and we won't for about another year, the report of the inquiry from the evidence that's being heard now, you already get a hint of it. I'm a member of the BMA, and we had, like the RCN, begged the Health and Safety Executive to stake their position on protection of healthcare workers, and they didn't. And the chair to the inquiry said, so what did you do? Did you just follow whatever IPC said? Didn't you have a duty at law to protect those people and to step in when you knew, an HSC, that surgical masks weren't good enough? So we can sense that there is going to be that pressure from the inquiry for the HSC to do what sadly it did not do when it should have done. And if the HSC doesn't step up to the mark, well, then other bodies, other groups, societies and so on should do that. And in any case, as John just said, and as John quoted earlier, safety reps have an essential role, and one which is safeguarded by law. And basically, as John pointed out, exposure at work is a huge contributor in the pathway, starting from exposure in the community, so-called, leading all the way up to people being hospitalized and dying. And it is really quite substantial. And the epidemiology shows that, and John illustrated it. And we mustn't forget that the workplace isn't just about workers. At law, employers have a responsibility under Section 2 towards their employees, but also under Section 3 to anybody affected by that work. That could mean patients in hospital, it could mean school children, it could mean people in a catering establishment, it could mean passengers on public transport. And therefore, when we address the risk in the workplace, we have at risk to do just that, address the risk to anyone in the workplace, and not just to workers. What we need, as John said, and as others have said before us, experts in the field like Lindsay Marr and Jimenez and so on, is we need to have an indoor air revolution, like there was a clean water revolution, if you like, in Victorian times, although sadly even that's being reversed sometimes when you see what companies are doing. But anyway, that's another story. We need to strengthen the evidence base, it is true, but we still have a great deal of evidence, although perhaps more needs to be done in terms of defining better the parameters for ventilation, engineering, and so on. Ideally, all stakeholders should engage, and I put the regulator first because that's where they should be. But if they don't step up to the mark, then others will have to. Maybe the inquiry will force them. And of course, everything has to be tested properly and evaluated, but that doesn't mean that we cannot start and make huge inroads with the knowledge we already have. So just as in terms of air quality for anything ranging from nitrogen dioxide to spray painting to silica to asbestos, the same principles apply. You look for hazards, potential sources of infection. That means basically other people. You need to identify the people who are at risk, not just workers. And as John said earlier, you try and determine from the time spent, from the number of people to whom one's exposed, the likelihood of them being infectious. Maybe even using supplementary stuff like carbon dioxide monitor, which I use quite often. And one needs to have risk assessments that are specific to job and work, because the methods of control, ventilation, and so on may vary. And all this needs to be reviewed. Now, many of you will be quite familiar with the hierarchy of control, which is useful. But I think for airborne infections, we need to look at it slightly differently. I mean, in a traditional hierarchy of control, you can have something like substitution. Let's substitute benzene by cyclohexane. Let's substitute asbestos by man-made mineral fiber. But you can't substitute a pathogen. You can only control it and get rid of it. You can't say, let's find a safer pathogen. There's no such thing. So in this paradigm, in this model, you look at sources, you look at pathways, and finally, receptor controls. That basically means those methods of protection specific to the individual. So we need to look at work practices to eliminate interactions. We need to, when prevalence is high, test and screen people, or at the very least ask them, do you have symptoms? Have some form of a questionnaire, just like there is for people with dermatitis, just like people who work in food hygiene are expected to report if they have diarrhea and vomiting, so steps to be taken. This attitude of letting it rip, we don't even need to bother to ask people or do anything about it, is a recipe for disaster. If necessary, people may need to isolate, yes, with support. We need to have a policy for staff who may be infected, maybe get them to work from home, or for staff who are susceptible, remote working, as per the Equality Act, get them to be protected by working from home or in other ways. Pathway controls, I showed you earlier my CO2 meter. That graph on the right shows my exposure when I went to my dentist, and that peak there of a carbon dioxide level, which is about nearly 10 times as high as it is outside in the street, was in the waiting room. So I promptly tested the windows. Only one of them could open. I opened it, sat myself next to it, and of course, put on my respirator. It will often need much more than just opening windows. It will need high efficiency particulate filtration, maybe ultraviolet irradiation if it's done properly. Barriers, if done properly. Many of the barriers put up during the pandemic probably made things worse rather than better, because there were barriers without ventilation, and all they did is just kept pockets of air in the doldrums. And even, as we've seen in the pandemic, cohorting, people with high risk being in one place and those in other places. And one can also have administrative measures, directions of flow of people to reduce exposure in the exposure pathways. I'm not an expert on ventilation, nor is John, and we both admitted that, but you need to get experts to advise on this and do it properly. There are still simple means. You can read guidance. There exists guidance on ventilation in a number of workplaces, including in the NHS. And you can have simple so-called setups like Corsi Rosenthal boxes, which make a big difference. But ideally, get expert advice. We now finally end up with receptor controls personal to the individual. There's PPE and there's vaccination. There are circumstances where even now PPE is absolutely essential. You all know of it in terms of asbestos stripping, in terms of car spray painting, and so on and so forth. PPE enables jobs to be done which could not be done without them. And even with ventilation, in circumstances like healthcare, if you are close to a patient and they may be a source, then you need to have adequate protection, because background ventilation will not be enough to protect you. And for those people out there, I mean, looking at the evidence that's been given in the inquiry, I mean, where do these people live? Where do they come from? Don't they know that workers have worn respirators for at least half a century, since around Robert's report, or in some instances earlier, in asbestos, in quarries and so on. That respirator there, incidentally, was the first one I wore in the pandemic. It was designed for miners, but unfortunately I had a stock of respirators at home because of the job I do. And even in healthcare, they've been used in open TB, in dental technicians and so on. If the health service was meant to use respirators for open tuberculosis, why on earth would they let the staff be exposed to COVID with just a surgical mask? And the HSC said this before the pandemic. In an airborne state, you should actually be using respirators. Sadly, when it came to the pandemic, they kept their mouth rather firmly shut. Hopefully the inquiry will prize it open. And the HSC's own research conducted in an excellent way, and I saw their facilities in Buxton. They were proud of it, the HSC, and rightly so. And they showed how protective respirators were in comparison to surgical masks. But when push came to shove, again, they didn't repeat that point. I will dismiss vaccination quite rapidly. Why? Well, first of all, it doesn't necessarily reduce transmission. It does reduce, if you get the right vaccine and if it is recent enough, the severity of illness. Some people can't be vaccinated or won't. And of course, when the next thing comes along, there's going to be a huge lag, like there was this time around, of about a year before vaccines come of age and are available. So vaccination is something which is an addendum to the protection methods that we should be using in workplaces. It is not a replacement. It is not what we should rely on first. Some people talk of vaccination plus. I talk of all the other things that we've just spoken about, plus vaccination. So really, this needs to be taken seriously. We need to have schools to take the matter of airborne infection as seriously as they tackle head lice. And we need restaurants and food hygiene establishments to tackle it as seriously as they tackle food hygiene. We need hospitals to tackle this as seriously as they tackle wound infection. And for those workplaces which claim to be health promoting, because maybe they serve rabbit food in the canteen or they have gym facilities or whatever, say to them, look, unless your risk of contracting airborne infection in your workplace is distinctly lower than that in the community, you have no claim to call yourself health promoting. And those are some references. The top one is to an editorial which I published only about a week ago. Thank you very much. Happy to take questions.
Thank you so much, Raymond. I mean, really, really excellent information there that I know I will find helpful, and our audience as well will be able to take some of that to use in evidence when speaking to their employer about making changes in the workplace. Okay, we've had quite a lot of questions. There's a couple of initial ones I'm going to answer. I know that my colleague Shelley's online. Don't worry, Shelley, I'm not going to bring you on, but just something I think we can perhaps work on together. A viewer has asked if they're going into a new workplace, could we put together a list of questions to help individuals and reps if they're going into a new workplace to things of ask of the employer? I think that's something we can definitely do. So leave that one with us, and we'll do that as the TEC. Okay, so first question that maybe we'll go to you first, John, and then come back to you, Ray, is how can we get an employer to come off the notion that COVID-19 is the new norm and we just need to learn to live with it now? What suggestions have you got for that, please?
Yeah, thanks very much for the question. Really important. It's hard work. You know, those of us who've been campaigning on this, you know, from the get-go, we've been up against a tide of misinformation coming from government, coming from employers and other official institutions. There's definitely been an agenda that, because of the disruption to the economy, and I'm not minimizing that for a moment, instead of looking to the science properly and looking how best to implement the protections, the response has been pretend it doesn't exist, pretend the risk is not there. And that's why you have all this nonsense that it's just like a cold and we don't need to test anymore, and it's a nothing burger, and masks are awful. How dreadful are they? What an imposition on our personal liberty. Anyway, everybody knows all of this stuff. I think you have to go in armed with information, and hopefully webinars like this and the TUC's education department and health and safety department have been helpful, and there's a lot of useful stuff there. Make sure you know your stuff, and I would raise it in an incremental way. They're not going to roll over and say, oh yes, fine, we'll do it. And I would also talk to your colleagues at work. Talk to the union, talk to the branch, get your members on side. And that's probably the first thing I would advise you to do. So it's not just you as a health and safety rep or a concerned worker, but you can speak on behalf of or part of a group of workers and saying, look, we're not happy about this. And then use the usual tried and tested methods of trade unionism in the workplace. You know, Go to meetings, go to health and safety meetings, say there's a dispute, you're not happy, and escalate it and so on. And go back to your region and nationally. There's lots of advice. The health and safety officers are there, and work with them. But it will take time. The important thing is to get the conversation going and get the members on board. Thanks.
Yeah, thanks, John. I think that's excellent advice. As with all issues in the workplace, the first thing to do is get it on the discussion table, get it on the agenda, and then take the steps that John mentioned there as part of your role. Have you got anything to add, Raymond?
No, really. When people say it's just like a cold, I will say COVID is like a cold in only one respect. You don't get herd immunity to colds. People in the pharmaceutical industry have spent billions over the years to try and develop, well, maybe not billions, but hundreds of millions, a vaccine for the common cold. It changes all the time, and the immunity we get from a cold disappears quickly. So COVID is the same, changes all the time, and the immunity disappears, which is why it is so dangerous, because it is much more dangerous as an illness than the common cold is. But just like the common cold, it is just as slippery. You cannot say we will become immune to this and it won't be a problem. It will be, unfortunately.
Thanks for that. That's another good piece of information that reps can add when discussing the issue with their employer. Okay, we've had a few questions about testing and testing before going into work, especially in the social care sector, where there is no encouragement or even discouragement to test. What are your feelings around testing?
I gave an analogy earlier of the food hygiene industry, where you're meant to report if you have diarrhea or vomiting, or maybe the way people have their hands looked at if they're in a workplace where dermatitis might be a problem. I think we need a system where if anybody is symptomatic or has been a contact of somebody in the household who is symptomatic, then those people should be tested. So I'm not saying it should be like it was at the peak of the pandemic, where in many workplaces everybody was tested, not in as many as should have been the case, but in some workplaces it was done, healthcare. But that if you have these response to a screen, then it should be tested. And if you do test positive, and incidentally, there are test kits out there which will do not just COVID, but will do respiratory syncytial virus and influenza, but then you should have a protocol in place which says, well, maybe this person can work from home, or maybe this person can work a respirator, or maybe they can work behind the scenes, but not in patient and resident contact, and again, wear a respirator and have a proactive approach rather than this laissez-faire, let it rip that we have now.
Thank you. Anything to add on that, John?
Just that it remains important, and testing is a vital part of a comprehensive range of measures that you need to put in place to control these viruses. I mean, we've emphasized ventilation and air filters and masking as their obvious airborne protections. But alongside that, you have to have testing, so at least you pick up who's infectious, and people can then isolate. And as well as that, you need to give people adequate time off work to stay at home so they don't come into work and infect their colleagues. Now, what's happening at the moment is, most people have negotiated their contracts at work before the pandemic, right? And in your contract, there's 4 weeks sick pay, something like that. Some people a bit less, some people a bit more. Then comes along a pandemic where the government and the employers don't do anything to protect you, and it's their job to do. It's the law that they should. And who pays the cost? You, the workers, pay the cost out of that sick pay, assuming you don't get really sick and have to stop work, or even worse. And lots of people have had that experience. But it really sticks in my throat, the way they have offloaded the cost. They failed to protect you in the workplace, and they offload the cost of infections on you. You use up all your sick leave, and then you start to get disciplinaries and all of that to manage future sickness or another round of COVID. So unless we have all those elements in place, we're not going to control this pandemic. Transmissions are going to carry on, and it is the workers themselves that are going to pay the price.
Yeah, thanks, John. I think the lesson from that is take a look at your workplace policies, or especially ones that were written pre the pandemic. As John says, there may be a different angle to look at them through now because of what we've learned in the past 4 and a bit years. Okay, so the next question is about CO2 levels, and I know we've had quite a few people ask about how you measure this. Now, John, I know you've got a little device because I've seen it when I've met you, a little CO2 measuring device. Can you tell us a little bit about that, where people can get them from, how they can use them, are they useful, that sort of thing?
Yeah, sure. I'm sorry I didn't bring it into the room that
Okay.
I'm in now. It's downstairs, but
Oh, look,
there we go.
can you hold that up to the camera, Raymond? Well, okay, great. So
Brilliant.
can you tell us a bit about yours, John? Because it's very similar to yours,
Yeah,
right?
it's exactly
Okay.
identical. So they are incredibly useful. Okay. That's an Aranet, which Raymond's holding up. Thanks so much, Raymond. And what I particularly like about it is the way it handles the data. It's a little bit pricey. It's about 150 quid now for each device. But if you buy them in bulk, there's a bit of a reduction. And the great thing about it is you can put it in your pocket and you can walk around the workplace or take it on the train. And Raymond showed us the trace of him in the dentist, and so on. I would be a bit careful about shirt pockets and having it close up in your breathing zone, because I was actually in a health and safety training day, and I had it in my shirt pocket, and I pulled it out of my pocket and it said like 1800. So I went up to the tutor and I said, "We've got to clear the room." And he said, "What? Are you sure? Are you sure?" And I said, "Hold on, let me just check again." And I moved it and it was like 800. So if it's in the breathing zone, remember when you breathe out CO2, it can falsely raise the level. But they are excellent devices to have. What I've been looking for some time is a union branch who will work with us to do a trial. So we give 5 or 6 workers these devices to walk around in their pockets, away from the breathing zone, for your whole shift over a period of a week. And then we go away and we download the data onto spreadsheets and everything. We do an analysis. And that will be very, very informative about where the hotspots are. And that's what it'll show you. It will show you the canteen. It will show you like small corridors or storerooms where there's no ventilation. But the important parts are where there's lots of workers together, or a few workers together in the same small space for a long period of time. I'm sure Raymond has more to add on it.
No, I don't think I have significantly more to add. Just to say that it is, of course, a surrogate, and there are other considerations in ventilation. But for starters, it's useful. It's not as specific as, for example, if you were measuring for solvents in a workplace where you were concerned about solvents. It's a surrogate. So, for example, because my study is quite small and the door is shut, it's showing a relatively high CO2 level of. Even though I put it down away from me, I only hung it from my pocket earlier to show how you can hang it there. But that's because I'm in a small room on my own with not much ventilation. It doesn't mean it's dangerous because I'm on my own. I can't infect myself. So it has to be interpreted carefully in the context of room occupancy and so on. But it's a useful screening tool.
I'm sorry, Anna, may I just come back on
Go for
a
it.
couple of quick points here? I think people may have been asking about what level is safe.
That as well. That was going to be my next
Yeah.
question. Yeah,
Oh,
a little
right.
bit about the filter, the vents, the devices, and then what level.
Yeah.
Go for it.
So look, all the experts are very clear. 800 or less is your yardstick. Unfortunately, government has once again manipulated the situation, and there's this figure of 1500 that's bandied about. It's wrong, okay? Now, that's a real problem because the guidance that does exist still talks about 1500. And so when you go as a rep to your employer and say, "Look, I've got some readings and they're 1400, the employer will say, "Well, look, the guidance says we only need to do anything when it's 1500. But if you're at that point and you're having that conversation, I think that's still a win. The other downside or limitation of of the aeronet on its own is it doesn't measure particulates. And there are other hazards in indoor air, as Raymond has said throughout his talk, and particularly particulates, PM 2.5s and 10s. And there are other devices. There's something called a King Ping device, which does measure it. It's not quite as convenient as the aeronet, but it's still a good device. And, you know, we should, while we're tackling COVID and airborne viruses, we should also be looking at air pollution, particulates, and other, you know, VOCs and so on in indoor air, which are also important for health reasons. Thanks.
That's great, thank you. And while you've been speaking, 2 viewers have said they're willing to sort of, you know, team up with you to test this in a workplace. I'll put you in touch with them after we come off air.
Great.
Okay. We talked a little bit about how in a workplace, the employer is responsible not just for their employees directly, but we've had quite a few questions that cover freelancers who maybe don't have quite the same protections in the workplace as an employee. Could you talk a little bit about that? How, if they are in a workplace, how they might be covered by some of this?
Why don't you go first, Raymond?
Well, when you say freelancers, of course, freelancers have if they're the employers, they have a responsibility to themselves. By what I mean by that is, if an individual had his own workplace and he was sanding furniture which contained a lot of lead, effectively he's his own boss. He still needs to protect himself. So the responsibilities are there as to who the boss is in that context, where we go into matters of contractual law, in which I'm not well versed. But the same criteria apply if somebody's job involves them being on the move, for example, if they went from household to household, for example, in the social care sector. Well, they would have a good case if the risk assessment suggested, if they're going to people's homes where there may be a high risk, to wear respirators, like something like that, with which you are all familiar, to protect themselves. This attitude that COVID's over, we don't need to do that, it's crazy. In some jobs, we still do.
Thanks for that, Raymond. Did you want to add anything, Jonathan? Or if not, I'll go to one more question I think that we can do before we wrap up.
One sentence. It may be down to you as an individual, and I hate saying that because this is not an individual response that's going to solve this problem. But if you can't rely on the employers and the workspaces you go into, make sure you've got a good quality, well-fitting FFP3, and that at least will reduce your risk substantially. And Raymond, thank you again for bringing the examples.
Got all the props, which is
all
great.
The props, in fact.
Props. We've had quite a few questions about FFP3s and other PPE, which I don't think we'll be able to get time to all today. But hopefully, you know, some of the information that we've covered in other questions will answer those questions as well. Sorry, I'm just trying to find the last question that I had about this. They keep moving around, so it's tricky. Yes. We've got people who may be particularly vulnerable with other conditions. I mean, the first one that jumps to mind is asthma, of course, but if there are other respiratory conditions that obviously affect people more. Do you have any particular advice for them that may be on top of what we've already covered?
Well, remember the equality law, it's there. People have got a right to request adjustments. They should have a right to an occupational health service which will recommend those adjustments. And if those are deemed reasonable by employers, of course, that could be employment tribunal territory, what is reasonable or what isn't. The employer has an obligation to do so. In fact, in the editorial which I published and you kindly put a link to, there is a link to a very good page written by a law firm on the question of reasonable adjustments. And I don't think any employer can turn around and say that for a worker to request those and is wrong. It's something which can be done in many jobs, remote working, and in all jobs one could use respirators for high-risk situations, although ideally you should try and protect exposure. And there are so many people out there who need better protection because they are susceptible. The law gives them protection, but unfortunately, they're not necessarily finding that in the workplace.
That's great, thank you. And any last words from you, John, before we wrap up?
Yeah, really important. And just to add, asthma is an obvious one, but remember, COVID is mostly not a respiratory disease. It's mostly a vascular condition, and it can cause all kinds of problems with all kinds of previous prior existing medical conditions. So if you have any clinical vulnerability whatsoever, I would try and engage with what Raymond has just outlined in terms of reasonable adjustments in the workplace. And of course, we're all exposed. And, you know, healthy people have ended up getting long COVID and have had to give up work, and their lives have been completely diminished because of this thing. So what keeps us all safe will keep clinically vulnerable people safe too. We're all in this together. We really are. And the more we raise it, the more we discuss it, the more we to make demands of our employers, of public transport, etc., etc. Eventually, that pressure from below, I think, will be the deciding factor in getting the protections into place. Thank you.
I think that's a great note to finish on from you, John. Thank you to you both for really informative and excellent detail, really, of things that people can take away. Thank you all for joining us. You've had some really insightful questions and great experiences shared in the chat. If you've told us that you want to test air quality, like John said, we will pass on your details to him. That will happen in the next few days, so don't worry about that. We'll make sure that you're put in contact. Thank you all for joining us again, and we'll see you again hopefully at our next webinar, which is on October the 10th. It's about mental health in the workplace. Do sign up to that, and have a good rest of the week. Bye bye for now.